So AIIHPC is pleased to be working alongside the Palliative Care Research Forum Northern Ireland, and they will be giving you a flavour of the research in the area of palliative care in Northern Ireland. The forum is currently chaired by Professor George Kernahan, who is a PCRN member, and George will talk to you about knowledge development in palliative care. George works in the School of Nursing at Ulster University, but he's said to say that he's not a nurse. He started with a science degree and then a PhD in orthopaedics, and he describes himself as a career researcher with a long-term interest in taking small steps to help people living with chronic illness. George, I'm delighted to hand over to you to MC this event, and thank you very much.
Thanks very much, Claudia. It's lovely to have a chance to talk to people, and I gather the recording may be available afterwards for those that aren't able to join. You're welcome too. So this is a chance for me to try to put a few join a few dots, I suppose. Knowledge development is a complicated process by which we start with an idea or a question and hopefully end up with something that can improve practice or help people. I've begun to see that as something of a journey, and I'm going to tell you about how that journey unfolds for me with some examples. But I suppose before we get into the journey, the screen shows the 6 key messages of Palliative Care Week. It's worth rehearsing them just to let you know some of the principles that underpin palliative care and palliative care research. Often people think that palliative care is only available at the end of life, but it can benefit people at all stages of illness and people of all ages. You tend to think of it too late in the process. So part of Palliative Care Week is to try to let people know that it's a supportive type of care that's available at all stages of illness, right from diagnosis on. It can benefit quality of life of people with advanced cancer, which is the most common area for palliative care still, even though it can help in heart and lung disease and dementia and other types of illness as well. So it's for all stages and all types of diseases. The third point is that it can be provided for years, and not just at the very end of life, but some people have long periods of being well, moving in and out of palliative care. It doesn't necessarily lead, to death and dying. Naturally, we all get there in the end, but palliative care can be offered as a supportive intervention, and then you can be discharged and then come back in again whenever it's needed again. It improves the quality of life of family carers as well as the quality of life of the patient themselves. So there's an important emphasis on making sure that the family members are supported. You'll hear a bit more about that from one of the research projects that we have. It can be received in various settings. You think of the hospice, but it's also palliative care in hospital. It can be in a nursing home or even in your person's own home. And although physical symptoms are pretty fundamental, the other aspects of emotional, social and spiritual needs are important as well. Not just important, but they can have measurable quality impacts. It's interesting as a researcher to unpack some of the benefits that are there beyond the physical symptom control. So when your spiritual and social needs are addressed, it relieves some of the, particularly the psychological impact of an illness. So all of those tend to start to raise questions, and those questions about the timing, the interventions themselves, the effectiveness of what is done, the referral in and out. So these messages, when you think about them, lead us to ask questions about how best to deliver palliative care, which is really the fundamental question that underpins a research project. So the summary of what I would like to do in a few minutes is to talk a bit about evidence-based practice, which is the practice of using research effectively. Evidence-based practice, we've learned quite a bit of it in the pandemic, where the politician speaks about referring to the science or the evidence and being informed as much as they can in the situation when there was a shortage of evidence. But the evidence is found in various places. It can be found in research papers in the scientific journals, but it also comes from experience, from professional experience, and it can come to some extent from the patient's own experience and their preference. You've got to really understand that evidence, it's a bit like a plot or a series of core strands that together generate outcomes for patients. The research on its own isn't enough. The professional experience on its own isn't enough. And the patient's preference on their own isn't enough. But harnessed together, they can become very effective. So translating evidence into practice is quite a complex thing. We have to carefully plan the facilitation and make sure that it's understood, it's the reasoning and the context that we're working in is quite a big player in how evidence becomes evidence-based practice. So here I want to go on a long journey, as quick as I can, from a basic research idea through a number of steps and stages. My particular sort of lens will be used. I'll use my own examples. Now, you could call on examples from anybody from a range of parts of the world to illustrate this, and you might have your own points along this journey. So the idea is to go along this journey with me and try to get a better understanding of how research works and how research can help in palliative care. So I'm sitting here in the attic in my hometown of Bangor, and that's there just to break the talk up a little bit, but also to show you that there's a starting point to your journey. Mine is a starting point in a town by the sea, and you take the journey by car sometimes, by train sometimes, or on foot, and you can take a journey in different ways to reach a similar destination, or to go on a long journey with many parts that might involve some parts on foot, some parts by public transport, some parts by car, might drive to the airport and so on. So even thinking about a geographic journey, you unconsciously find that it breaks down into different parts, and quite often you can do the same journey in different ways, just for variety or for to avoid a problem. You can work around. So some of those things are useful to bear in mind, but this is partly a physical journey as much as it is a research journey. It starts with research or a research question, and hopefully the intention is to reach a practice change or a practice improvement to influence practice. It looks on this slide like a straight line, but it's not really straight. It can be a bit wavy. It can hit ramps along the road. We need resources to support the research. So funding is a bump along the road. There's approvals that are required, both in hospice or the hospital and in the university where I work. They can be a bit of a delay. Then when you get further on down, different types of research are supported in different ways. So it's a journey starting with an idea or a question, going through a series of little mini projects that advance the knowledge. So the knowledge comes along the path. So in some ways, we've got to find where the current position is on the track, and then advance a little further. So this idea of a journey, I think, helps to sort of map out the complexity. Palliative care research as a journey. So we start in a familiar place where we are now, and that's the starting point, that we're facing some kind of issue or question. It's like being at home. The starting point is kind of familiar. We know where we're starting from, and we ask a question to challenge the knowledge. What does this particular type of care do? What are the outcomes? When should it be applied? What does it mean? What are the really important issues for the patient right now? And the idea of asking questions, not taking things for granted, but asking questions is the starting point. Then you get to a literature review, which is finding out what is already known, what is already written, what can we find out from the existing knowledge, and that's a little project on its own, to search the literature in the library, arrange the evidence, put it together and synthesize it and make sense of it. So that's a step. That's the first step. Quite often the next step is qualitative. Now, qualitative research looks at concepts and meaning. A bit like, if you think of how you're listening to me, that's a qualitative experience. You're listening to words and hopefully making sense of the journey that I'm speaking about. That's a qualitative experience, and the learning and experience is a qualitative function, and that's also a type of research, to clarify what we mean by things, to ask people to speak about their experience, and putting that together. That's another step on this journey. All right, so we've got a question, we've got the literature review done. Now we're clarifying the meanings and the concepts by asking people to talk about them. That often leads on to the next bullet point, where we try to construct some kind of architecture within the conceptual process. So we put things into order. The concepts might come in a natural sort of time order. So what came first? How did you feel after that? What about whenever you were diagnosed? So you can put the concepts into a time, into some sort of order, or some sort of framework that theorizes a bit about, if this happened, then that followed. So the qualitative understanding helps us to draw the map of understanding. Having done that, you can keep going with the journey and become a bit more quantitative. This might be the research that you're a bit more familiar with, where we actually count things and measure ideas, maybe measure pain, try to measure pain. That's a hard one. But things like referral patterns, duration, time points, these are all identifiable in a way that can be counted and measured. So as you can see, the journey takes us through from primarily a qualitative starting point and then becoming quantitative, where once you've got the concepts clear, you then can work out how they are measured and compared. Comparisons is a big part of research, where the same thing can be done in two ways and we make a comparison. Sometimes there's natural variation that we like to harness as researchers. In one hospice, one special way of doing things happens, and then in another, it's slightly different. So by making measurements of outcomes, when there's natural variation, you can begin to get some ideas about which is best or which works best in which circumstances. So that then, the final part of that one is a trial where the researcher has an opportunity to change the way things are done in a care setting and measuring the outcomes as well. So that's sort of the peak type of research whenever you go through this journey. When you get to the point of a trial, you're getting the strongest type of evidence in support of that intervention. But we always have to remember there's these three forms of evidence. There's research evidence from trials and all the work that we do to generate new knowledge. But then there's what happens in practice, how it works whenever you're not in a controlled environment, how it works at night whenever there's less resource, how it works in an untrained pair of hands compared to somebody that's very experienced. So there's quite a big step to take from a research solution into a practice solution. And it has to be something that works for patients and they can accept it as well. And then there's a whole other step of the process to do with implementation of that evidence once you have lined up the research, the practice, and the patient's their preferences. Implementation takes account of the context of our work. So these are complicated processes of knowledge development. Thinking of them as a journey helps me to work out where the knowledge is and what should be the next step along the way. It's important to have some way of thinking about all this complexity that allows us to make a bit of progress. I won't have a lot of time to give you a lot of examples of this, but I think it might make sense to mention one or two things that illustrate how different projects work at different points on the journey. The big idea is to build on what previous workers have done and go another step along the way to make better decisions about practice and make palliative care a little better than it is at the moment. So there's an assumption that you can always do a little better. You can always make a small change that has an opportunity to improve symptom control, to improve the family carers' quality of life. It doesn't always be a huge dramatic solution to a disease pathway. The big idea here is to make a small step along the way towards improving palliative care. So a few examples to try to illustrate that, starting with a literature review. So this is a piece of work asking what's the value of attendance at palliative daycare. That's something that I've worked in for about 4 or 5 years to try to understand what is palliative daycare, what does it achieve, and what value is obtained from that type of outpatient service where you go along 1 day a week and have symptom control and have social support. So the first part of that journey was, well, what does the literature say? What do the papers say about palliative day care? And this piece of work was a systematic review that involves all these authors in reading papers and organizing them into meaningful contributions. So without going into a lot of detail on this, the literature helped us to understand the process of daycare, that there is quite a lot of referrals, quite a lot of interventions, quite a lot happening by different people in different places in different ways. The literature suggested that daycare is highly variable. And then I went on and did some more work. But the point here I'm trying to make is that the literature review is one of the first steps on the knowledge journey. Then we go on from the literature review to qualitative research. Remember, this is whenever we have conversations and we allow people to have a narrative, or maybe they might write a diary and try to understand the meaning of a situation. In this case, the authors were working in Nepal. So we're looking at an unusual context for us, I suppose, where there's very limited resource, people living in poverty, still requiring palliative care whenever they have their chronic illnesses, like anywhere else. So the starting point for that, after having done some literature work, the next point is to do some qualitative understanding. So providing palliative care in rural Nepal, what are the perceptions of those that are there trying to provide it, the perceptions of the mid-level health workers in trying to provide symptom control at the end of life in that type of setting. So that involved talking to these mid-level health workers, and without going into a lot of detail again, and just to try to highlight how qualitative research makes a contribution and takes you a little bit further along this journey. So 4 themes emerged from the discussions with these mid-level health workers. The suffering of the patients. So there's aspects to identify whenever these conversations are analysed. The helplessness and frustration that they feel whenever they're caring for patients, and that some socio-cultural issues at the end of life that are particular for that, as well as how to improve the care for patients with palliative care needs. So some challenges, obviously, in a challenging setting, but some ideas for how care may be improved. So only by asking questions and recording conversations and trying to do that understanding can you then go on to try to ask the next question, which would be how will we improve the situation for these people. So that's a bit of work in itself. It hopefully will lead on to another step along that particular journey. Now, this one is interesting because it kind of straddles both qualitative and quantitative. This is work we're going back to day services again, and this one was asking, what are the indicators of good quality care in palliative day services? This is a complicated method where you start with a qualitative piece of work, but in the same project move on to quantitative within the same stage of within the same research project. Let's look at the abstract and see if I can explain this a bit more. This is where you would ask experts, so like perhaps the audience today, you would gather from an audience or from a group of people an initial qualitative understanding of, in this case, indicators. Then you list them and identify from one round of work what the qualitative evidence shows, present that back to the same people and say, right, here's what everybody said. Would you help us now by putting these into order, confirming that these are the important indicators, and help us to rank them or weight them in some way. That's a kind of mixed method. Quite a lot of researchers go to mixed methods, thinking that because you're going to use both qualitative and quantitative, so it must be a better way, but not necessarily. Because it just so happens that this works quite well, and you can move from qualitative into quantitative. So what did this say? Can you see the results? There were 182 indicators, quite a lot of indicators that have to be selected, ranked, and organized. You need to go into a bit more detail if you want to find out exactly what they are. So this bit of work took an area of study. So what are the indicators that would help us to achieve quality outcomes? Ask the people that are involved in that type of work what they are, identify them, list them, and feed them back to the same people, getting their help quantitatively to put them in order or to weight them so that you can end up with a refined list and hopefully a useful way to move forward along that journey. So where can we go with this now? We've got a whole journey ahead of us, I suppose. The last one that I'll speak about just for a minute is a survey to try to looking at components of care. What are the components of dementia palliative care, where people have cognitive decline and they're forgetful, and then that deteriorates into more of a complex scenario. A community model would emphasize caring at home or in the community. This is a bit like the previous one, only this one is done by a straightforward survey. So questions are asked and answers provided and subsequently analysed. This one is survey methodology is sort of a little bit like that previous one, where there's qualitative aspects being asked and also some quantitative aspects as well. The idea is to survey those that are involved in delivering palliative care for people with dementia, asking them what are the main components of care for people with dementia. Let's see if I can pull out some of the meanings up here. There's over 100 complete surveys, key principles. Many people described holistic and person-centered care as a core framework. Individual components were supporting the carers, advanced care planning, information, activities for meaningful living, comprehensive disease management, coordinated case management, linking with other services. Barriers to good care was poor availability, lack of organisation, stigma associated with the disease itself and with palliative care, misconceptions around dementia, insufficient advanced care planning, and dementia-related challenges themselves, and there's some facilitators. So you can get into quite a lot of detail with a survey methodology to help find out where improvements might be made and get ideas for how things are done successfully. So that's some illustrations along the journey. I'd like to allow a little time for you to reflect a little bit about where you think you're starting and what kind of steps you can take, and also realize that developments can happen where quite a modest bit of work along a long journey can take us a little bit further. So by doing this survey of 100 responses, you can find out a little bit more about what a community model of dementia palliative care is. So by asking fairly well refined and defined questions, collecting data carefully, you're able to make contributions to knowledge, and that means you're moving along this journey towards improving palliative care. Okay, I think we'll probably find that journey will be illustrated by other speakers this afternoon. I should stop the share for a minute and see if we're ready to conclude that, and see if I've got a Cherith sample ready to lift the baton for me. So how can we build a little bridge? The journey that Cherith's going to go into a bit more detail on is family life when a parent is at end of life from cancer. So this is a family-oriented question. Hopefully there'll be some parallels to be drawn with the kind of knowledge journey that I've been speaking about. Researchers don't always realize that there's a long journey before them, and there might be quite a long journey ahead of them. So if you would spend 10-15 minutes helping us to understand where this project sort of fits on a journey, if you can, that would be good. Trying to see if there's any parallels. So family life when a parent is at end of life from cancer. Cherith, whenever you're ready to.
Can you see my screen okay? Is the purple screen up?
Yes.
Yeah. Well, good afternoon, everyone. I'm not so sure who's on screen here today, but I'm very pleased to be here. And George has been speaking about a journey, and I would have to just comment by starting to say that George and my journey started almost 20 years ago, because George was one of my supervisors for my PhD. So I was just reflecting on that while you were speaking, George. It's hard to believe that time has gone past. So over the next 10 minutes or so, I'm going to share a little bit about our Family Centred Cancer Care Programme of work. And I'm going to particularly focus in on the end-of-life component, which is relevant hopefully to the audience here, especially with it being Palliative Care Week. This has been a number of projects, and we'll just look at that in a few moments, but I would have to say, as you can see, this work has been primarily funded through the cancer charities locally, and I'd like to say thank you to our cancer charities for enabling a lot of this work to take place. So as I had commented on, I didn't realise what George's talk was going to be on, but this is a programme of work that has taken place out over the last 10 years, and it's building on the evidence starting off in 2010, and we're going to just focus on today where we're at in 2020. I'm not going to go through every step here. That is something, and I'm just going to give a little plug. A colleague of mine, Dr. Jeff Hanna, will be presenting this programme of work in much more detail on Friday, and that's at a workshop, and I think there's a couple of spaces still available down in Newcastle in the Venue Bean Cancer Fund for Children. But just to share where this piece of work did start, whilst I was out doing my PhD for 3 years full time, I came back into the clinical area just after that. I worked 17 years as a head and neck clinical nurse specialist up until about 3 years ago when I got a permanent clinical academic appointment between the South Eastern Trust and Ulster University. And when I came back into clinical practice, one of the key things I was seeing was an increased number of younger people being diagnosed with head and neck cancer. Typically, our head and neck population would have been gentlemen primarily. There was a preponderance of men and a ratio of 2 to 1 versus females. And they were more often in that age bracket of between 60 and 70. But we were starting to see in 2010 this increase in younger people, which is clearly denoted on the screen, as you can see there. And at that stage, we weren't exactly sure what was driving this, but we've got certainly a lot more clear picture of that HPV virus is directing that. And Professor Tanya McCats and myself got a little pocket of money from Action Cancer and conducted a literature review and also a qualitative piece of work looking at the experience of parents with head and neck cancer, because I was very cognizant in my day-to-day practice that the support needs of this subgroup of head and neck cancer patients was very different from what I was used caring for. So I then scoped the literature a little bit further and to see the size of the problem essentially, or the prevalence of patients or parents with cancer of young children. And I've put some of the statistics on the screen just here, where in the United States, population-based study estimated that 10% of newly diagnosed cancer patients are aged between 18 and 55, which again is an age range more often when people are parenting. And then Weaver et al. In 2010 demonstrated that 14% of cancer survivors have young children. Looking at Finland, this was again another very large cohort population-based study that followed children who were born in 1987 through into their adulthood, and 6.6% of children who were born followed up had a parent with cancer in their childhood. In the UK, we have no comparable figures, but the CRUK figures are fairly static out over the last 5 to 10 years, with about 10% of people diagnosed with cancer being aged 25 to 49. And then most relevant to this talk today, a study from Norway demonstrated that 20% of individuals of a parenting age experience death while parenting dependent children. So we're going to look at the 2020 block in red here today, which is managing parental cancer when mum or dad is at end of life. And this is 2 separate studies. Again, it just filters quite nicely into what George was saying, in that there's a journey, but there's a journey even within this subgroup of what we're looking at today, because we did start off with a systematic review on the challenges and support needs of parents and children when a parent is at end of life. And then that followed on with qualitative studies. This formed part of Dr. Jeff Hanna's PhD, and the systematic review was had 27 studies within it. And what we did find from that piece of work, that parents often avoid telling their children the reality of mum or dad's prognosis in an effort to protect children. We also discovered from this systematic review that there was often opposing parental beliefs on how best to tell the children, and that acted as a barrier. And parents who do not have a clear understanding of their own prognosis were often unsure of how to tell their children. So if they didn't know the significance of their diagnosis or prognosis, that once again presented as a challenge or a barrier to communicating their diagnosis with the kids. And parents were most often concerned about difficult questions. The difficult questions that parents were struggling with considering was, if my kid asked me, how or when am I going to die? How could they appropriately answer their kids, and how could that question be answered? This systematic review did demonstrate that often parents feel ill-equipped on how to share their diagnosis with their children, but they have that desire for instructive support from health and social care professionals, but it's often lacking from the healthcare teams. So as part of this end-of-life study, there was 4 study populations with 79 participants, and this included end-of-life parents, bereaved parents, health and social care professionals, and funeral directors. So it's a very large body of work, and this afternoon we are just going to focus on one of the study groups, being bereaved parents. And this piece of work has recently been published in Palliative Medicine. I've done quite a few qualitative studies over the last number of years, and I'd have to say this was one of the studies that I found most challenging, but I found most rewarding. And it was an absolute privilege to go into bereaved parents' homes and hear their story and learn from that, and more importantly, what we as health and social care professionals can do to support parents at this very, very difficult point in time in their life. So we're going to look over the next few minutes at the key themes that came out of this qualitative piece of work. The first theme was emotional readiness to share the poor prognosis with the children. Initially, we discovered that the parents felt it was too painful to consider telling the children that them as their mum or dad cancer had returned and they weren't going to survive their illness. First of all, they needed an opportunity to get their heads around it first before sharing. But we also discovered that the well parent wanted to be involved in this communication with the kids. The reason for that was twofold. They wanted to protect the spouse or their partner from the distress that may be encountered from this. But they also were very aware that them as the well parent would have the ongoing parenting responsibilities, and therefore wanted to be part of that conversation. We also find as another theme, and this was a very predominant theme, and you'll see that from even the title of the paper, Living in Parallel Worlds. This is where these two worlds were going on simultaneously at the same time. There was more often the parent was wanting to live in the moment, and then periodically there was these intermittent glimpses that death was approaching. And when there was these intermittent glimpses of death was approaching, that then provided an opportunity to get some advanced planning put into place. And as you can see in the previous slide, I had shared how we as health and social care professionals can support families whenever they receive the poor prognosis, that news that their cancer is no longer curative, or they're an end-of-life aspect of their journey. Where for us as health and social care professionals, it's important to give honest information and advice on how best to prepare for the future, and also to provide guidance on how best to tell the children. But living in the moment, as I mentioned, was a more predominant way of living, and most families wanted to savour the moment. So with this, there was 3 sub-themes. there was life goes on, the striving to live, and making the most of ordinariness. And we'll just look at those in slightly more detail. So life goes on. There was a lot of effort placed in trying to maintain routines. And also if the sick parent, that parent who more often was undergoing still some palliative form of treatment, if they could participate in some of the parenting responsibilities, they were very keen to maintain and engage in that, despite their physical constraints, maybe like making the pack lunches, or if they couldn't drive the kids to school, to maybe like go with them or on occasions be there at the school gate. And this was really driven by a keen effort to protect the children. They also were very keen that family life went on, in that the kids went to school, they still continued to engage in their extracurricular activities. However, when death was more imminent and that unwell parent was physically less well, actually they may not have been able to physically parent in the same way, but what was crucially important was still having that presence, being in the room when the kids were doing their homework, being in the rooms when they were watching the TV or they were on their tablet, because that actual presence still maintained a connectedness and a supportive aspect for not only them, but for the children. So the striving to live, the second sub-theme at this juncture. One thing I would just write over this is that striving to live is looking for hope. So hope was in two ways. There was like the hope in the treatment and hope from their spiritual faith. These parents were aware that they had an advanced cancer. They was aware that there was no curative option, but they still put a lot of emphasis on modern cancer care therapies today, especially with novel immunotherapies. And for some people, there was excessive optimism in the potential outcome for that treatment. Also, for families or individuals who had a strong spiritual faith, there was that hope of healing from their cancer. And for some people, this remained right up until the day of death. And for some families, this sense of hope from their spiritual faith that they would be healed from their cancer actually led to minimal or that lack of advanced care planning. And then the third sub-theme here is making the most of ordinariness. This was like trying to capture life as it happened. There was this evident desire for more family time. And often there was a lot of effort, and some family activities were very much engineered whenever the unwell parent had a good day, essentially, and just really had that keen desire to make the most of opportunities. And this was capturing life as happened. There was a sense of like taking more photographs and taking more little video clips, and birthdays. There was like more of an effort in celebrating birthdays, or for some other graduations, or whatever that might look like for that family at that time. Interestingly, one of the things that we did discover that a few did write letters for the future, but more often they didn't get around to it. It was just too painful to consider not being there with their children. And these were finding that too difficult to articulate and put down in a little card. More often the memory work was like capturing life as it happened, like I said, taking those videos, making the most of the birthday celebration. And another thing that we discovered from this qualitative study, that the memory work for some people that had been encouraged by the health and social care professional teams, that was perceived as an additional pressure, and something that they felt was being strongly recommended, but it provided them with extra pressure at the time where they wanted to still to continue with living and capture the moments and make the most of everyday life. So what we did discover then, there was a sense that people did have a variable number of treatment options, treatment lines. From one field, they maybe were offered another one. But there then was a certain point in time in their end-of-life journey where things actually became, that ill parent became much more acutely unwell. And parents did describe this sense of like they were falling off the cliff. They were running out of time. And this was generally either a few days or short weeks before the parent actually died. And at that point, there was a lack of parenting capacity for both of the parents. And there was an ardent need to maximize social networks. This is like making and ensuring that there were other people around to take the kids to school or whatever this might look like. So we've put this together in this infographic where we can see that the mum or dad receives a poor prognosis. There's a role and responsibility for us as health and social care professionals to try to support families in this very difficult situation. We can see here there's the purple line with the small little arrows within it, where there are little dips along the journey till we come to a point where things change very quickly and acutely, and there's then a very, on the whole, a very steep deterioration that leads to the parent's demise. So this piece of work then has led to informing, alongside some of the other pieces of work, how we as health and social care professionals can best support families, and moved this work into a talking, telling and sharing framework at end of life. And we're not going to look at that today, and that's something for Friday, because that will certainly take us well beyond our time. So I would like to say thank you for listening, and there'll be a little opportunity in a few moments for a few questions.
Thanks very much. Thanks very much, Judith. Yep, that's interesting how that journey kind of flowed very nicely. Thank you very much. And the journey carries on. Okay. I can see that Kieran is there on screen, perhaps ready to pick up the baton again. We're very glad to hear about the approach to pain control, pain services in the same trust. So I guess your colleagues, Charles and Kieran's, welcome. I think it's probably over to you. Southeastern Health and Social Care Trust Joint Interventional Palliative Care Pain Service, with the emphasis on joint, I think. Looking forward to hearing this. Thank you.
Okay, so I'm purely a clinician. I have been for some time. Actually, 20 seems to be the figure for this session. I've been a consultant for 20 years this month. I am working in the Southeastern Trust, and I'm going to tell you a little bit about the Joint Interventional Palliative Pain Service. It's a bit of a mouthful, so JIPS for short. So why is this service needed? The prevalence of pain in the palliative care setting varies hugely from 50 to 90%. And we know that patients with poorly controlled symptoms experience poorer quality of life. And the exact aim of most palliative medicine interventions is to really help to relieve this. There are 10 to 15% of these patients who have uncontrolled pain. So these are patients that are living with difficult and debilitating pain, who are often developing side effects as a result of very complex medication regimes that they're on, and they are also potentially in their last weeks or months of their lives. Based on the number of deaths per year and the prevalence of pain in the palliative population, I think we can estimate that there are between 1,500 and 2,200 patients that may have uncontrolled pain. So currently, there is no funded interventional pain service for patients with palliative care needs in the Trust and the Greater Belfast area. Looking at elsewhere in the UK, there are interventional pain services available to patients who are palliative, who have a palliative care need, mainly in areas in London, Manchester, Liverpool, Glasgow, and Aberdeen. So over the years, several palliative care patients were referred on an ad hoc informal basis to a consultant in pain medicine at the pain clinic, and really with noted beneficial outcomes. But this process was rather informal and ad hoc. So in the last 2 or 3 years, because there had been an expansion in the palliative medicine workforce in the Trust, and also a chronic pain anesthetist with an interest, combined with the specific need in a particular subgroup of palliative care patients, it allowed this service to start developing over the last few years. And whilst this was developing, we thought that it would be necessary to keep a register for these palliative care patients. So we started to keep the register from August 2018 to August of this year past. So when the service was started, initially there was very quickly a realization that there were going to be referrals not only from within the Trust, but also from palliative medicine consultants elsewhere. And to be able to have a standardized collection of information, we thought it best to have a referral form to help the process with patient info and clinical details. And these forms were emailed to all palliative medicine consultants. So what happens during the process? There's a joint discussion that occurs with the referrer by telephone or video call, where there's the type of procedure is discussed, possible risks to the patient, information that needs to be given provisionally to the patient, other relevant information, for example, how to arrange an ambulance that would be adequately staffed with medical staff, because there are issues that can happen post-procedure. It's difficult to get even an ambulance to wait for an hour or 2 hours to collect the patient, so we have been able to use certain services, ambulance services that help us do this. So if the referrer confirms that the patient wishes to go ahead after discussion with the patient, appointment details are confirmed, and the patient attends the Ulster Hospital, the chronic pain service department, as a day case. There is then full consultation with consent, and the patient after the procedure returns back to either the ward if they're from within the hospital, or goes back to their unit, accompanied by a doctor in an ambulance. So the whole process from start to finish is actually quite short. It occurs from about 10 to 14 days, which is really important for these patients because the prognosis is fairly short. Interventions need to happen quickly without a waiting list, because we need to make sure that we are able to offer something useful at the right time. And I will discuss a bit more then about the demographics, including the prognosis, in the next few slides. So the register from August 2018 to just August past, we have had a collection of 30 patients with a total of 49 procedures. So retrospectively, we did collect whatever information we could obtain before August 2020. And from August 2020 onwards, we decided that we needed to collect some information in order to inform our practice and also to help our case to prove and to show that this service was providing some benefit and it needed developed. Now, 7 patients discussed didn't have a procedure, and these were for a combination of reasons. Either their pain improved or their condition deteriorated over the week, or it was felt that the particular service we offered wasn't appropriate and other recommendations were made for other options and services. So the demographics that we have obtained so far showed that the cause of pain for patients, 26 of them were malignant pain and 4 were non-malignant. Average age, 63 years. Average time from procedure to date of death was 64 days, so really quite short. So this is the median number of days to death after the procedure, which really shows that the majority of patients are in their last months of life. So the GIPS activity to date, this illustrates the different types of blocks that were offered. So we've broken them down into peripheral, sympathetic, musculoskeletal, spinal, and general. So the majority would be either peripheral blocks or spinal blocks. And spinal blocks include interventions such as nerve root blocks, epidural, intrathecal, and paravertebral blocks. So quite a variety of procedures, including those for general pain using lidocaine. And I suppose the use of lidocaine was really to address a particular patient who had total pain. And so there were repeated infusions of lidocaine in a particular patient. So when a patient is assessed, not only is their cancer pain dealt with, but if they have other pains that are contributing to their overall pain, for example, from a non-malignant source, if the anesthetist feels that there is something that can be offered at the same appointment, that is also performed. So, as I mentioned earlier, alongside carrying out this activity, we felt it was necessary to collect as much data as possible for those patients that were referred, particularly after we established that the referral process needed to happen. So we collect the data for all patients referred, and we have done this from August 2020 right up until August this year. These are really for patients that we deem we want to collect a full data for analysis, so they are included in our pain survey. The referrers were mainly palliative medicine consultants. So these are patients who really have very complex pain issues, and we have had referrals from several hospices, the Northern Ireland Hospice, Marie Curie, Antrim, and we've even had a patient coming all the way from Omagh as a day case. We've also had a patient from the Cancer Center who was then transferred to Marie Curie and then transferred for the day for a pain procedure. And once the patient has completed and the procedure is done, we request our referrers to complete the survey for us. So this is what the pain survey looks like. We obtain all the demographic details, the performance status, likely prognosis, and what procedure they actually had. And there's really quite a lot of information that needs gathered, and we are looking at the medication, particularly the analgesia, pre-procedure, and then 2 or 3 days after, and then about a week after that, and then day 21 to 28, so 3 to 4 weeks is the last collection. And we look for information not only from the regular medication, but also on the as-needed breakthrough doses. We also inquire if they had had any problems with medication side effects. So these are mainly opioid side effects, pre-procedure, drowsiness, myoclonic jerks, confusion, hallucinations. And we collect this again at all the different time scales mentioned. And then we also are trying to get some information, and this hasn't been particularly easy, about the functional ability. So has the patient been able to sit on a chair? Have they been able to stand, walk short distances? Do they have bowel control? Because a few of the procedures can affect bowel or bladder function. So it's rather exhaustive, and it's not easy to get these pain survey returns. So early data, just to give you a flavor of what we have seen so far, and this is from 10 patients. Pre-procedure dose, so this is the dose of the opioid analgesics before starting. So the percentage drop about a week to 10 days after the procedure is down to 50%. And in 3 to 4 weeks, it drops again, and it's about a third of the original dose. And on asking patients about the benefits and the referrers, most patients have found the procedure to be definitely helpful, and they would also have the procedure done again in hindsight. And all the referrers felt that either probably or definitely helpful for pain management. So the benefits from the intervention noted so far: pain relief is usually instantaneous after the procedure, and this is quite satisfying to see. And this is really because of the effect of the local anesthetic and the phenol agent if it's used. And over the week after the procedure, the patient may have a bit of a difficult time due to the fact that we request that the patient's analgesia is reduced just before the procedure to allow for the fact that with the reduction, we are trying to minimize any risk of toxicity from the very strong opioid drugs. So when the medication needs re-titrated up, it can be a difficult time for the week after the procedure. But after that, from about day 10, there's usually a marked reduction in the opioid doses. So this also corresponds with less overall side effects, and so a much better and improved quality of life. And this is especially of great benefit in the last weeks or months of life. So overall, the pain reduction has a beneficial effect not only on the quality of life, but also potentially in the lifespan. And I need to look more into this. But I guess the general feeling is that pain is a very powerful stressor. So removing this stressor relieves the body of toxic compounds which can affect the overall lifespan of an individual. So with any new service, there are challenges. This is a small service run mainly with my colleague and myself, with help from our colleagues in our two specialties, palliative medicine and chronic pain. We're based in the Ulster. This is not funded. It runs alongside our existing resources from chronic pain and palliative care. If the service is to grow and expand, it requires adequate resources and staffing, and this includes protected consultant sessions, clinical nurse specialists, radiology input, pharmacy, and admin support. Patients are required to be either in hospital or inpatient hospice unit before and after the procedure because, as I mentioned earlier, their drug management needs careful titration and to avoid the risk of being very toxic from opioids, which can lead to death. We also have considered that We may at times require an availability of an inpatient bed at very short notice if a patient becomes unwell after the procedure. We have to remember that these patients are very ill, they can be very unstable, and they can have several coexisting medical issues that can very quickly make them become unwell. From the survey to collect the data, we are still completing the data collection. It has not been straightforward. The last table, the day 21 to 28, is not always completed. And this is because the patients may be discharged and they may have different clinicians involved. And the patient may have deteriorated in the meantime, etc. Also have to say that looking at benefits of the service, the cost saving from being able to reduce their opioids, and there are different types of patients are on different types of opioids, has been a cost saving there in the reduction of the opioids, but also much bigger reduction in the fact that some of these patients may be able to be discharged a lot earlier from their either hospital or hospice stay, so saving on bed days. The progressive nature of this, of cancer, makes it quite difficult sometimes to compare before and after the procedure because there are several coexisting variables that are changing all the time. And so the pain pattern can change and you may not be comparing like with like. The quality of life information for patients with advanced palliative care conditions, it's also challenging. Other types of pain may be unmasked whenever you help one site or type of pain and you remove this, and then other pains which were being masked then become apparent. And so it's actually difficult to measure then the quality of life when you improve a particular type of pain. So these are all challenges from collecting information from the survey. So currently we are completing data collection and we are going to be analyzing data for 18 patients in total from a year's worth of data from last August to this year. We then hope to write this up as a service development and also do a case series and gather all the outcomes from the data, which will hopefully show that there's been of benefit to these patients. The plans tend to submit for publication. So now I'm just going to tell you a very short case history and patient journey of an 80-year-old man who had a diagnosis of lung carcinoma with bony metastases in his ribs and vertebra. He was admitted to hospital with severe pain in his back, unable to move, only able to lie flat. He had a very sharp pain in the middle of the back, and he rated it as 10 out of 10, and no amount of analgesia was helping him. And because he was in extreme pain and unable to move, an MRI spine could not be done, so this was requested, but on a couple of occasions, he was not able to be brought down to the radiology department to have this done. So he was referred to the GIPS service for consideration of a nerve block. The procedure was explained and the consent obtained for intervention the following week. This is his X-ray, and as you can see on the right, the vertebral collapse at the 9th thoracic vertebra, which was the main source of his back pain. So this was seen under X-ray imaging just before the procedure. So what was performed was a thoracic epidural, both above and below the level, so T8 and T10. And following this procedure, the pain improved over the course of the week. He was able to have his MRI scan 3 days later. And the report, as you can see, it's pretty obvious. And there was a burst fracture at T9 with retropulsion, which was causing spinal cord compression. And of course, they were looking at there would be great risk of causing spinal cord compression. And so after the scan confirmed this, he was referred for emergency radiotherapy, both to relieve the pain and also to prevent impending loss of power. Following this, then he was transferred to a hospice unit for ongoing care, and he died then several weeks later. So just, I think that case illustrates to you really, maybe makes it seem as if it's a much more of a real life situation when you can see a case going through the referral process and then the data being collected. So I hope it's given you a little bit of insight as to what the service does and why it's for, and hopefully we'll be able to get a bit of information over the next few months and try and get it out there.
Okay, thank you. Thank you.